and continuous neurological monitoring. This data table tracks surgical outcomes, documenting a 16% reduction in postoperative neurological deficits when operating under the Awaik protocol compared to general anesthesia. This method allows surgeons to maximize the extent of tumor resection while actively preserving patient quality of life. Achieving these outcomes requires an anesthetic strategy directly dictated by the underlying neuroanatomical landscape. We must map exactly what we are protecting. This anatomical profile highlights the primary eloquent regions, the primary motor strip, Broca's area governing expressive speech, and Wernicke's area controlling language comprehension. Any surgical approach near these zones mandates real-time functional assessment. Look at the clinical alert on this summary. 90% of intraoperative neurological symptoms do not occur during cortical resection. They manifest during subcortical manipulation, particularly when navigating deep white matter pathways like the arcuate fasciculus. Because the risk is overwhelmingly subcortical, preserving the electrophysiological fidelity of these deep tracts is the primary objective of our anesthetic plan. We cannot afford to suppress the signals we rely on to guide the surgery. Securing this electrophysiological fidelity begins well before induction. A mandatory multidisciplinary assessment must occur at least 7 days prior to surgery to establish the patient's baseline functional performance. This flowchart maps the specific day -7 dependencies. The patient, neuroanesthesiologist, and neurosurgeon must coordinate to select 20 to 30 reliable naming objects and rehearse the exact tasks the patient will execute during the Awaik phase. This preoperative window is also where we encounter a widespread pharmacological error, the routine administration of prophylactic antiepileptic drugs. This clinical protocol matrix includes a critical pharmacological warning regarding antiepileptic prophylaxis. Initiating these drugs in seizure-naive patients provides zero measurable reduction in intraoperative seizure incidence. Instead, it introduces unintended psychomotor slowing and decreased attention spans. Furthermore, initiating a new antiepileptic regimen within 2 weeks of surgery is contraindicated. The body requires time to develop a tolerance to the sedative effects of these drugs, and their presence suppresses the exact neural responses we intend to map. Preoperative pharmacological optimization ensures the patient arrives in the operating room with a clear cognitive baseline, entirely unmasked by unnecessary medical intervention. Intraoperative success relies entirely on regional anesthesia. A complete scalp block provides the hemodynamic stability required to keep systemic sedation to an absolute minimum. This schematic details the bilateral blockade of 6 essential cranial nerve branches. We systematically target the supraorbital and supratrochlear nerves anteriorly, the auriculotemporal and zygomatic temporal laterally, and the greater and lesser occipital nerves posteriorly. Beyond the primary nerve trunks, we must thoroughly infiltrate the Mayfield pin fixation sites and the planned incision line. Failing to adequately anesthetize the periosteum here guarantees a sudden, severe autonomic surge during cranial pinning. This data grid breaks down the exact local anesthetic formulation. We use a dual-agent mixture combining the rapid onset of 2% lidocaine with the sustained duration of 0.5% bupivacaine. We add 8.4% sodium bicarbonate to neutralize the acidic pH of the mixture, significantly reducing injection pain. Because of the high volumes required, we rigorously track our maximum allowable doses to prevent systemic toxicity. Bupivacaine is strictly capped at an absolute threshold of 3 mg per kilogram of body weight. A meticulous regional block is the anchor of the entire procedure. It is the only variable that allows us to safely suspend systemic analgesia during the critical mapping phase. The most reliable anesthetic approach for prolonged Awaik cases is the asleep, awake, asleep, or SAS technique. It divides the surgery into 3 distinct temporal phases. These target-controlled infusion curves map our precise dosing strategy. For Phase 1 induction and opening, we target an effect site concentration of 3.0 to 4.0 micrograms per milliliter for propofol, coupled with an ultra-short-acting remifentanil infusion at 2.0 to 4.0 nanograms per milliliter. Tracking the monitoring data over Phase 1, we secure the airway with a laryngeal mask airway to maintain spontaneous respiration. We simultaneously target a BIS spectral index, or BIS, sedation depth strictly between 40 and 60. Timing the emergence is unforgiving. Both propofol and remifentanil infusions must be completely discontinued 5 to 10 minutes prior to the planned awakening to ensure clearance before the dora is opened. For Phase 2, the Awaik mapping phase, the ideal pharmacological state is 0 systemic medications. If the patient is completely unmedicated, the functional mapping is perfectly reliable. If sedation is absolutely necessary to manage distress, we rely exclusively on dexmedetomidine at 0.2 to 0.7 micrograms per kilogram per hour. It provides vital anxiolysis while explicitly preserving respiratory drive and avoiding amnesia. Precise pharmacokinetic titration is the only way to navigate this narrow therapeutic window, preventing catastrophic awareness during opening and avoiding dangerous oversedation during cortical testing. Once the patient is awake and communicating, we transition directly to intraoperative direct cortical and subcortical electrical stimulation. This visualization models the bipolar stimulation probe parameters. We apply a biphasic alternating current at a frequency of 50 to 60 Hz. We start with a conservative 2 mA current, incrementally testing the tissue while the patient performs specific cognitive tasks. As the tumor resection deepens, the required current drops. If we trigger a positive language or motor deficit using less than 3 mA of current, it indicates the probe is within 2 to 3 millimeters of a critical, eloquent white matter tract. Resection in that vector stops immediately. Throughout this process, the anesthetist continuously monitors electrocorticography, or ECOG. Any electrical after-discharges persisting longer than 5 seconds indicate a highly irritable cortex and an impending seizure. By combining precise stimulation parameters with continuous ECOG monitoring, the surgical team safely identifies the absolute functional boundary of the tumor cavity. The immediate response to intraoperative crises occur. Focal or generalized seizures manifest in approximately 12% of Awaik craniotomy cases. The immediate response to an ECOG after discharge or clinical seizure is not pharmacological. The surgeon must instantly flood the operative field with 4 degrees Celsius sterile saline to shock the cortex and suppress the electrical spread. If cold saline fails, we immediately escalate to IV propofol boluses. If the seizure remains refractory, we push IV midazolam or phenas, preparing for an immediate conversion to general anesthesia. A far more lethal intraoperative crisis is an airway emergency, typically precipitated by intraoperative vomiting or profound respiratory failure while the patient's head is pinned in the Mayfield frame. This flowchart tracks emergency airway retrieval times. The data confirms that rapid reinsertion of the laryngeal mask airway is the superior first-line rescue tactic, demonstrating a 100% success rate within a median time of just 6 seconds. If LMA placement fails to restore ventilation, it is left in place to serve as a direct conduit for secondary rescue via fiber optic intubation. When the patient's skull is physically clamped to the table, standard intubation mechanics disappear. Pre-rehearsed, device-specific crisis algorithms dictate whether an airway loss is a recoverable event or a fatal surgical failure. The intense vigilance of the operating room extends directly into the postoperative phase. Patients require a mandatory 12 to 24-hour admission to the intensive care unit. For the first 6 hours post-op, comprehensive neurological assessments must be conducted every single hour, tracking Glasgow Coma Scale, pupillary response, and specific motor and speech functions tested during the Awaik phase. To manage reactive cerebral edema, we administer scheduled 4 mg doses of intravenous dexamethasone every 6 hours, carefully monitoring blood glucose levels. This summary outlines our exact postoperative care parameters, highlighting a strict analgesia protocol. We strictly avoid all NSAIDs for the first 48 hours to minimize any risk of postoperative intracranial hemorrhage, relying instead on acetaminophen and the residual effects of the scalp block. Despite our mapping precision, patients often awake with minor temporary deficits due to surgical manipulation and localized swelling. The clinical data shows that 90% of these new transient neurological deficits resolve entirely within 30 days. The rigorous demands of the Awaik craniotomy protocol, from preoperative cognitive benchmarking to real-time subcortical mapping, are validated by these exact numbers. We accept a higher intraoperative complexity to guarantee a profound acceleration in baseline neurological recovery.